You ready?
I am ready.
All right. Well, good evening. I'm excited today. We are going to be talking about a topic that nobody wants to talk about. So people have a tendency to do the three monkeys, no see, no hear, no talk about this topic of hospice. And it is probably the most misunderstood word in the healthcare industry. So today we've got Jennifer Buddenbaum who's going to come in and kind of explain to us, and we were just having a conversation beforehand, which I'm going to get her to talk about again. She had a perfect experience about just how much people don't know what it is. So, Jennifer, would you introduce yourself, who you're with, and let's kind of tell me what's going on here.
Absolutely. Well, thank you for the invitation for this opportunity. Again, I am Jennifer Buddenbaum. I am with Dignity and Hope Hospice and Palliative Care, and I am the marketing director, volunteer coordinator, and community education specialist. So, a little bit of everything out there. Um, yes, it's one of those topics we had talked about. I have been in the senior care industry for almost 4 years, rubbed elbows, and Jim can attest to this. And every meeting we went into, there were multiple hospice companies and representatives, and hospice this, hospice that. I kind of knew that it was for people that have terminal illnesses, but never really understood what it was. I just kind of like, oh, I don't want to talk about it. They're talking about death and dying. And, although all of us are going to die at some point, it's just one of those taboo subjects. And I was telling Jim before we went live here that I didn't understand really what hospice was until my mother entered into hospice care. She was told by her physicians that she should go on hospice care. My dad went through a list of companies, chose one, had a horrible, horrible, horrible experience with the first company that we went with. And I said, "What's this hospice thing all about? I don't get it." And then had lunch one day with one of my colleagues who was with another hospice company. And she said, Jennifer, I don't care if you go with our hospice company, but here's the experience you should be having. So went back that evening, literally as I was driving home from work, called my dad and my sister and was like, this isn't what hospice should be. Went with another hospice company, went with my friend's hospice company actually. And to tell you that it was, to lose a parent is horrible, but to have the positive experience we had when my mom was at the end of her life, you can't really put it into words. I joke and say if the case manager can put up with my family, they can put up with anybody. I mean, we were not an easy to get along with family when it comes to your mom, and she got a say in what her end of life was going to look like. And now, as you see, I'm with a hospice company and really, really want to educate the community on just what a positive experience that hospice can be for families.
Well, I think that myself, if I could have gone back in time with what I know now to what I knew then, when I started getting it, as you said, we're out at all these different networking. We were talking to all these people in these different parts of the industries and hospice, and became aware that it was much more than what I thought it was. Some time ago, I was always under the impression, and I think this is probably one of the bigger impressions that's out there, that it's morphine the last few days. Okay, that's kind of what I think a lot of
Yeah.
people think it is, and so when my father would have qualified for it because he had a terminal cancer for at least the last 2 years of his life, but we didn't even think about it, and the doctor called in the hospice, and that when he went into a coma, and then the lady showed up that day 5 minutes after he died. Now I was pleased because she did all the paperwork, but my mom and my dad would have benefited tremendously had they had those resources for 2 years as opposed to 5 minutes.
Absolutely. Absolutely. And that's one of the things, and we'll get into it here. I've got a little PowerPoint, as I mentioned, that I'll go through, but people benefit. And if you look at the research, people on hospice typically live longer than those who don't go on hospice care. But everybody thinks it has to be, when they're taking their last breath. But absolutely, we really encourage, medical professionals, families, whoever we're educating, the sooner that someone can go on hospice, which is, when they have 6 months or less, or their prognosis is 6 months or less, that's when we need to talk to them. Let's have that conversation, because when you get to that critical state where they can't make decisions, or, the power of attorney or the healthcare representatives are kind of making decisions in crisis mode, that that doesn't benefit anyone. So as soon as you have that prognosis, um, that's when we want to start having conversations with the patients as well as the families.
Well, very good. It's like I actually, and I don't. And now I'm drawing a blank on. I could see you sitting there, but there was a gentleman that was in hospice. He was on the west side of town. He was a marketing guy. And one day we were out at one of the coffees or what have you, and I asked him, I said, "Okay, now talk to me like I'm 5 years old, and I've never heard the word hospice before. Tell me what it is." Okay. And what he described, I thought was absolutely phenomenal. In fact, I made him write a blog, and it's on our Life Skill Pilot website, okay, on this. But he said that most doctors, or almost really all doctors, are taught curative medicine. Okay, so they basically are taught how to cure you, make you better, what have you. If you have an incurable situation, that could be tantamount to torture, as they're just trying this next thing or this next
Yeah,
drug or what have you. Where he said, as with the hospice, it's treating rather than the cause, it's treating the symptoms so you feel better. So if you feel better, maybe you sleep better. If you sleep better, maybe you eat better. If you're eating better, maybe you hydrate better. All of a sudden, you're feeling better and you can do things you couldn't do before because you feel better.
exactly.
And I thought that made so much sense to me the way he put that in words. So
Well, and a lot of medical professionals, and we're getting over that hump as, it's become more popular. We just heard about Jimmy Carter and how he was on hospice care. And so there's more dialogue that we are hearing now about hospice. But medical professionals, they really didn't want to recommend it. They didn't want to talk about it because it almost was that feeling like they had failed. And as you said, they are taught to cure, to make people feel better. But we all know that's not always the case. So we're getting there gradually with education, and getting medical professionals to talk about that topic and to identify, this isn't failure. Your patients look at you as the expert in healthcare, and this is just specialized care that you're recommending for them.
so what's the downside? Is there any downside to making the decision to go to hospice?
You know what? There was really not. Um, we're working with a family right now, and the son keeps saying, "Please don't mention the word hospice around my mom." Well, mom's talking hospice out of her mouth right and left. Like,
Right.
she has grasped and she's okay. She
Hmm.
understands that she is at, as we say, the end of life's journey, or, her prognosis is 6 months or less. Now, some people live longer. You and I network every month with a gentleman whose mom's been on hospice for 3 years, but she continues to qualify.
Hmm.
So as long as CMS looks at a qualifying diagnosis or terminal illness, you can continue to be on hospice. I mean, there is no downside. We're paying for it and we're not using it right now. Medicare covers. It is a Medicare covered benefit, and a lot of people don't recognize that. They first go to, "Oh my gosh, it's got to be so expensive. There's no way I can go under hospice care." Well, it's a Medicare benefit. As long as you are eligible and you have that terminal diagnosis that qualifies, Medicare will pay 100% of it.
I also understand that if somebody goes, "Well, going on hospice," I think a lot of people think that they're just like signing themselves over and they're done. You can pull out anytime you want, can't you?
Absolutely. And you know what? Again, a lot, if you look at the research, people on hospice care live longer than those who choose not to go on it. But you can go on hospice care, and my mom is a great example. She was diagnosed. They call it failure to thrive, but that's not really the diagnosis. It's calorie deficient malnutrition. Losing weight, kind of not eating, and we put her on hospice care per the doctor's recommendation. Next thing you know, she is gaining weight like you would not believe. She became, I called her the mayor of the assisted living. She was walking through the halls, talking to people. I mean, we saw the side of her after she went on hospice because again, she felt better. She was
Right.
eating, she was gaining weight. So absolutely. I mean, it just people don't see the positives. We at one point did take her off of hospice. You can elect at any time. And even if you elect to go off hospice, you find down the road, and we get many of these phone calls. Mom was on hospice, dad was on hospice, really started to plateau, was doing great. We took them off hospice. 8 months later, they started to decline again, back on hospice.
Yeah.
Absolutely, you can do that. You're not stuck on hospice. It doesn't mean that you've given up. Absolutely does not mean you've given up.
Well, I think a lot of people are afraid of that. They're afraid that once they sign that over, then they're not going to go to the ER anymore. They're not going to get any kind of treatment, you know. So it's like, for instance, my dad, you know, had a terminal cancer diagnosis, but we're somewhere in the middle of that process. I don't, you know, how all that stuff goes. You know, you're in and out of hospitals and whatever. He was really ill and was throwing up, you know, and just it was bad. And so they were going to go in for a surgery because they thought there was blockage or what have you, and they basically were telling us not to expect him to come out. Okay, that type of a thing. When they got in there, the doctors were freaked out because it was a congenital thing that he'd had forever. He had like a tendon that was pinching off this one part of the thing. They just took a thing and clipped that tendon, and he was fine. Okay, so with him, he could have, if worst case scenario, he could have gone off hospice for him to go into there and then come back if he had to. Right?
Absolutely.
Yeah.
Here's a case in point. We had a patient who fell and ended up injuring her head, needed to be put in hospital. At that time, you do go off of hospice because you want to make sure Medicare is paying for that visit, whether it's part A or B, whatever that hospital stay would be. And then when she is released from the hospital, she can go back onto hospice care. So it doesn't mean that, we're going to leave you in bed suffering when you need to go to the hospital or you need specific treatment or, if you get a UTI while you're under hospice care, that doesn't mean we're like, oh, sorry about you. No,
Yeah.
absolutely. That's not the case.
I do believe a lot of people believe that though.
Oh, I'm sure. Absolutely. They do.
Yeah.
Absolutely. They do. Now, when it comes to hospice, however, we only treat the terminal illness,
Right.
but you
Exactly.
will still have your primary care physician who will treat all other symptoms and manage all the other, things that might come along the way. So no, it's not like you are set. We'll treat the terminal illness. We'll make sure you're comfortable with that illness and anything else that might come up. Absolutely, you will work with your primary care physician to seek whatever treatment in that area you need to.
Well, that's the part that I really was wanting to make sure people knew about because I think that that is a very strong belief out there that once you sign that over, you're basically saying, "I'm not, you know, don't resuscitate me, don't." It's like a DNR, but on steroids type thing. You know, stuff.
I mean, in a certain, you're not seeking curative treatment. Like
Correct.
if you have terminal cancer and the treatment and the risk and the, just kind of outweigh the benefits, then yeah, you're not going to seek curative treatment. But at the same time, as we talked about, you're going to seek treatment for the UTIs, or if you fall and hit your head or break your arm, you're not just going to lay that. You're going to seek other treatment. So it's definitely
Right.
one of those misconceptions that's out there.
Yeah. Well, great. So you want to get a chance to show us your stuff?
Well, yeah, I just put together a real quick PowerPoint to talk about hospice and palliative care. And then we're going to debunk some of those misconceptions you and I have been talking about so far.
Okay.
So give me a second here. We got to find it. There it is. All right. So, as I had told you before, it's Hospice and Palliative Care Month. We celebrate National Spaghetti Day. It seems like every day there's something celebrating, but it is that opportunity with Hospice and Palliative Care Month to kind of educate the community as well as, kind of thank the hospice caregivers, if you will, because if you stop and think about the work they do, it's really special and they're very busy. Like, we need to recognize the work that they do for those that are end of life journey, as we would say. So here's the mission and philosophy of hospice care. So this is where a lot of people get confused. It's specialized care. And I always tell people, and I'm not a football person, but think of it as special teams. If you're in a football game and you got to punt the ball, you're going to bring in a special team. If you have cancer, you're going to see an oncologist. When you're at the end of life or have that prognosis of 6 months or less, you're going to get hospice care. It's that specialized care because everybody deserves to have respect and dignity at the end of life. Do you want to be hooked to all kinds of, machines or, whatever it might be, pain-free? Now, there is that misconception that people think everybody that dies is in pain. That's absolutely not the case. Some people are not in pain, very peaceful. But if someone is, for example, has cancer and they're in pain, or, have backache, or we don't want them to have pain. And then also, we want them to be in an environment that promotes the quality of life. So again, I kept saying, as my mom was in hospice, this really wasn't my mom. My mom's the lady who liked to go out and do lunches. She liked to go and take that cart and push it through Walmart and pick up things she didn't really need for that day, but she, would buy them because it was on sale. That was my mom. But seeing somebody laying in the bed, that wasn't quality of life. So we work to make sure that people at the end of their life, that we really try to promote that quality. And this is what throws people for a loop. They think it's all about the physical, but it's actually holistic. Think of the whole person. And it's an interdisciplinary team. I'm going to show you a diagram here in just a second, or a picture of what I mean by that interdisciplinary team. And we are going to focus on the physical. Obviously, if there's pain, whatever that might be. Also the psychosocial, because you know what? If you've been given the prognosis of 6 months or less, that sometimes that's hard to really kind of grasp. And you start to go through all of those things in your mind. I wish I would have done this, or, it could also mean, oh gosh, I've kind of had some dissension between me and my sibling for a while. I just feel bad about that. So we're going to, offer that psychosocial help if we need to, as well as spiritual needs. We have a chaplain. Everybody has a chaplain of some sort. And everybody's like, well, what if my loved one wasn't a religious person? You know what? We get that. Not everybody. Religion, spiritual means something to different to everybody. So we will work with them on whatever. They might have their own spiritual leader. They might have their own cultural, spiritual rituals. Hospice totally respects that and understands that. One of the things that we tell people, the benefits of hospice are greatest when services are provided early. So not only the patient, but the family and the caregivers can be surrounded by this team of committed, compassionate, and caring experts. So not only are we providing services to the patient, but we also provide education to the family, to the caregivers, because I had no clue. What I've seen of death is in like the shoot 'em up shows on TV. I thought everybody got shot by a gun and grab their chest and fall to the ground. And come to find out that's not what death looks like for everybody. So they will educate kind of through the process. Or, we get often asked the question at the end of life, they're really just not interested in eating. How can we get them to eat? Well, that's kind of part of the process. Or they really just aren't as social as they used to be. That's part of the death process, the dying process. So we will educate families. As I mentioned before, it could be where, maybe a mother and daughter, they just never really had that relationship. And the daughter is just really torn up about, what could have been with her mother. And if there is that possibility to make amends for them and to work with them and provide them resources. So that's why we really encourage people Believe it or not, we run across a lot of people who really don't, as we say in the industry, they don't have their business in order. And I'm sure, Jim, you've run into this where they don't have a living will, they don't have a power of attorney, they don't, they don't have a will. And so you've probably been sitting there like, I got all this stuff in the house. Who gets what and what am I supposed to do? And we can work with families to make sure that they have everything buttoned up that they need to have at the end of the life. So when they pass, they can pass knowing that their business has been taken care of. So here's that model, the image that I was talking about that interdisciplinary team. So you do have a physician. We have a medical director. Every hospice has a medical director. So it's not just some team out there making decisions. These are medical decisions for your loved ones. A social worker. It could be a situation where mom is in hospice, dad's still at home. Dad's never cooked his own meal in his life, and now dad's going to probably go hungry because he doesn't know how to, scramble an egg. We can see if he needs Meals on Wheels. It might be where they need attendant care, somebody to help dad or mom with a shower in the morning or help them get ready for bed at night. We can make those referrals for attendant care. So we have a social worker who will work with the family to see if there's any resources that we can help them with. We have a bereavement coordinator, which a lot of time goes along with the spiritual coordinator. So, and we'll talk about this in just 2 seconds here, but even after someone passes, they can still continue to be on hospice care. For 13 months following death, we can provide bereavement counseling, materials, resources. Some people, they're okay with losing their loved one. They understand that, what their belief might be, that there's something beyond this life, or they're just at peace and don't need that. But we run into some people who just really need that extra support, especially around the holidays. This could be the first holiday without a loved one. And we can give them some resources and different tips and tricks on how to get through this time. We have RNs, we have LPNs. They'll work on the frequency just depending on where they are in the progression. It might be one time a week where the nurse will stop in just to kind of do an assessment, see if there's any changes. Toward the end of life, it could become a daily visit just to make sure they are comfortable, etc. Specialized therapist, if needed, dietitian, and volunteers. So I mentioned I was the volunteer coordinator. CMS requires that we can show 5% savings of what we do through volunteers. It could be administrative, so they work in the office, file, answer phones. But we have quite a few volunteers who go out and actually provide companionship to the patient. They might do the dishes for a patient, light housekeeping. So there are volunteers that work with our hospice patients. Our hospice aides, I'm telling you what, they are amazing. They go out and provide some of those, daily, ADLs as they're called, where we'll go in twice a week and help them get bathed. We'll comb their hair. We'll do lotion on their hands, whatever it might be. We have hospice aides as part of that interdisciplinary team.
I will tell you, back in the day when I first started dealing with my family and dealing with all the senior stuff, people would throw these ADLs out there like they thought I knew what they meant. It's the activities of daily life. It's kind of like we have a tendency in I come from a real estate background. We all speak in acronyms. Yeah, but it's,
exactly.
Yeah.
So yeah, the activities of daily life. So those ADLs, we'll help them with those, help them get dressed for the day. And one of the cool things about hospice is we will go where someone calls home. So they could be in their residence. They could be in assisted living, skilled care. They could even be in a hospital, memory care. Wherever that patient calls home, that's where we will go. We already talked about the rest of this. Everybody's like, oh my gosh, hospice care is so expensive. We mentioned it's covered by Medicare Part A. Also Medicaid and most private insurances cover hospice as well. And then also we will cover under hospice care any medications that are tied to that terminal illness or DMEs. How do you like that acronym?
There you go.
Those are the durable medical equipment. So if someone needs a hospital bed, they need rails on the hospital bed, they need a walker, a wheelchair. Sometimes they will need one of the lifts. If they are too heavy for our aides to lift, we will get them the lifts, etc., to help move them. That's all covered under that Medicare. So here, this was when I started, with Dignity and Hope with our company. It was like, okay, help me out here. What's hospice? What's palliative care? So hospice, again, it is for those who have that prognosis of 6 months or less, where we say the burdens of treatment outweigh the benefits. And we specialize with those that I don't want to say closest to death, but again, 6 months or less. A lot of people will live longer than that 6 months, but they're no longer seeking that curative treatment. Now, palliative care, that could be someone who has cancer. They are still seeking treatment, but we need to really focus on their pain and their discomfort. We focus on that, quality of life, because if someone is in pain, that's not quality of life. We'll help them reduce the stress, help them, anyone living with that serious illness. So it could be somebody who doesn't have that prognosis, but again, they want to work with a company, work with, whoever it might be, to help ease that pain and discomfort. So they can still seek curative treatment, unlike hospice, where you're no longer seeking that curative treatment. So let's run through these, and we've talked about a lot of them. So if a patient chooses hospice, whether it's us or any other hospice, it does not mean they've given up hope. They just want to focus on comfort. They want to focus on quality of care. And although cure is no longer a goal, as we said, research shows that people receiving comfort care, and we talked about this too, Jim, if somebody is sleeping better, they feel better, they're going to have a chance of living longer because they're getting, feeling better, taking better care of themselves. So there's about a 29 days on average that they live longer than those who don't seek hospice care. Hospice is a place where people go to die. And there are in-house, if you will, places where you go for hospice care. But again, we go where somebody calls home.
But that's the
They
exception
receive,
as opposed to the rule, isn't it?
pardon?
The place of going to a hospice is the exception as opposed to the rule in most cases.
Absolutely.
Yeah.
And I want to say there's not a lot of hospice facilities because people do want to stay in their home. Now, if there's a situation where their discomfort or their pain cannot be treated in their home, then absolutely we will recommend that someone would go to a hospice facility, for lack of better words. We have a contract with Witham Hospital, so if someone needs that additional comfort care and we can't do it in their home, we can use beds with them, and we will work with their team to provide that care. All right, this is huge. People think if they go on hospice, they're going to die faster. I don't know how to tell people this. My mom was one of those. She thought going on hospice, it was going to hasten her dying. In fact, one day she fell asleep and took a nap, and my sister was there, and she went in to kind of tell mom she was leaving, and she shook my mom's leg, and hey mom, I'm gonna go now. And my mom woke up kind of startled, and she looked at my sister and she goes, "Oh, I thought I was gonna see Jesus." And my sister was like, "Well, sorry to disappoint you, mom, but not today." So my mom thought it was just one of those things where immediately once we put her on hospice, she was going to pass on, and not the case. It doesn't hasten it. It doesn't postpone death. But it's just there again, as we said, to provide that comfort and peace at the end of somebody's life. We've already talked about this. Again, it's not for those that, only have days or hours to live, because by that point you kind of lost out on the whole point of the interdisciplinary holistic approach. Yeah, absolutely. If someone's at the end of life and we get a call, we will go in and help provide, make sure they are comfortable, um, and do whatever we can during that period of time. But again, if somebody has a prognosis of 6 months or less, we recommend getting a hold of a hospice company at that time because, again, and it's not like you're forced to take advantage of all of the services that are provided. You can kind of pick and choose if you want. We have some people who want that whole menu. And then there are some people that are like, you know what? No, thank you on the social work. We have a really good handle, or no, thank you on the chaplain. We have our own spiritual leader that wants to come in, or whatever. Um, may not want to volunteer. It just, you can kind of pick and choose. But again, you've got that full menu. And I know that sounds, kind of cheesy, but again, you've got a full menu. And if you can take advantage of bits and pieces of that to bring your loved one and bring your family comfort and get resources, why not take advantage of it?
I think I'm not. You can tell me better than I, but I think I've heard that the average person is only on hospice like less than 7 days.
Yeah.
But I think it's self prophecy because they believe it's only for that, and they don't call until they're right at death's
Yep.
door, and they
Yeah,
don't take advantage of the opportunities.
Jim Morgan, you've done your homework. No, I mean that is, I mean, that's what research is showing. And looking to grow those numbers of days, because again, it's a benefit that Medicare has set aside for you for 6 months. So if you have it for 6 months, why not take advantage of it? And maybe you only take advantage of some of the services or resources in the beginning. And then as time progresses, if someone does continue to decline, you can kind of start using more of those resources. So yeah, it's not just for the days or hours at the end of life. If you choose hospice, you can't see your primary care physician. Nah, that's a myth. You can absolutely keep your primary care physician. If you've had Dr. Bob for the last 25 years, we're not going to tell you you can't see Dr. Bob and he can't continue as your primary care physician. The only thing is, we will communicate with him. Here's the care plan that is being recommended. He will review that care plan, either accept it, change it, whatever it might be, but we're going to start to kind of coordinate care with him or her, whoever your primary care physician is. Sometimes people don't have a primary care physician and they'll choose to use our medical director. A little quicker access, if you will, and getting things signed and moving forward with things. But again, it does not, no way, shape, or form are we saying you cannot continue with your own primary care physician. Hospice is expensive. Well, you've been paying for hospice since you've been paying into Medicare. So every time you look at your paycheck and you see that little line where they took money out for taxes, go down to the next line where it says Medicare, you're paying for it. So it's expensive on the front end, if you will, but it is covered by Medicare, it is covered by Medicaid, and most private insurance plans. Patients they are not denied hospice regardless of ability to pay. So a lot of hospice have foundations built into what they do so that they can help provide care for those who don't have Medicare, Medicaid, or private insurance.
Well, we have a wonderful facility here on the north side of Minneapolis that takes in indigent clients for hospice and stuff like that, and has a house for them and everything like that. So it's for everybody.
Okay, you and I need to chat because I don't know if I'm familiar with them.
Oh, really? Okay, yeah. That's we'll get with you on that one.
Yeah, like
You need
my
to meet
eyes
them.
are lighting up because I mean that just warms my heart knowing that indigent people have the ability to have, at that special place.
The Abbey Bryce House is what it's called.
Oh my gosh, yes.
Yes.
I've heard of them, but I didn't realize that's what they were for.
Yeah.
Awesome.
I'll get you with Madison. So she's like she's the person there. So
Yeah, love it. All right, working through these. Hospice only lasts for 6 months. We don't put you on for 6 months, and if you live longer, we're not going to kick you off. The only way that you will be discharged from hospice is if you're no longer eligible, meaning your terminal illness is no longer really terminal, for lack of better words. You're not eligible by the eyes of CMS from Medicare. So it could be like my mom, who was, basically starving for a period, malnutrition, and started to gain weight. And so, it might be that she is no longer within that window, if you will, of BMI where she could be eligible. So she is no longer eligible for hospice. So it's not a sad thing. It's kind of like a, hey, that's yay. You know, things are looking up. They're doing great, and continuing to progress in their healing process. Hospice is only good for administering pain medication. You want to shake somebody and be like, that's not what we do. Um, you know what? We have a lot of patients who we are able to manage their pain through maybe something as simple as a Tylenol, acetaminophen. Um, Sometimes it's really not pain. It's just they're laying there and they're thinking about things, and then all of a sudden they kind of thoughts creep over to, wow, does my back hurt? Or, I think my legs might be hurting. We can redirect sometimes through different, methods of redirection. Some people are really into that essential oils. And, we could maybe have some different smells or scents, or music is a big thing. It will distract them from thinking about their pain. Now, obviously, if someone is in crucial serious pain, we're not going to be, oh, try music. But we will work with them on different ways to manage that pain. So it's just not about the medication. Absolutely not just about the medication. We talked about it before. We're going to provide that spiritual or emotional support in addition to that physical care. Here's one. My mom has dementia. Why? She doesn't know what's really going on. She doesn't even remember her own name. Why would we want hospice care? Because most hospice companies are going to have dementia trained professionals. There's a lot of behaviors that come along with dementia. There's a lot of behaviors that come along with dementia at the end of life. We know how to manage those behaviors. Whether it is through distraction, redirecting, or sometimes they might need some medication because they have not slept for days. And everybody knows your body needs rest. So we might just give them something to help calm them down so that their body can rest. So we will work with them. Excuse me. And many families have felt that they're getting better quality of care and that their needs are being met more with hospice for someone with dementia, than those at the end of life who don't go on hospice care. You talked about this. A lot of people think, oh, it's kind of like signing on the dotted line. I can't turn back now. No, this isn't like that new car that you sign off on and you drive away, and once you drive off, it's yours. Um, you can leave hospice care and come back at any point that you want to, as long as you are eligible. It's that whole eligibility criteria that's important. So if you go on it and it's not for you, or you go on it, here you go, and you don't feel like you're getting, that company is not providing the care that you were expecting, or you're not getting the communication that you expected from that company, you can leave that company. You're not bonded to them. You're not tied to them. You can leave them and transfer care to another hospice company. We're getting there. You talked about that. See, I told you did your homework, Jim. Other medical care is not available to hospice patients. Again, while the hospice team will provide all aspects of for the illness that qualifies a person for hospice, hospice patients are free to seek treatment for unrelated illnesses or conditions. For example, if someone is receiving hospice care for heart disease, falls and breaks their arm, again, we're going to make sure you get treatment for your arm. You're not just going to have to lay in bed holding your arm. We're going to make sure you get to a hospital and receive the appropriate treatment. Only the doctor can refer someone to hospice. No, 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 no. If you have a loved one that is continuing to decline, and there's a kind of like a checklist, and if anybody ever wants that checklist that you can look at that kind of says, there's, uh, they might be eligible because they've had, 3 hospital visits in a short period of time. They're on 10 plus medicines that, there's just some different criteria that we kind of tell people to look through and do an evaluation. Because you know what? Evaluations are free. That will say whether, they are eligible for hospice or not. And if they're not eligible for hospice, maybe the home care would be the better solution. So anyone can refer someone. If you go to our website and many hospice websites, it'll say refer a patient. So you could refer your mom. You know, now you don't want to refer your neighbor if they have someone overseeing their care just because you're mad at them. Yeah. But
You can
again,
refer
anybody
yourself,
can,
couldn't you?
pardon?
If you have a client that doesn't have family or whatever, they can refer themselves.
Oh, absolutely. And you could refer your neighbor if they didn't have someone overseeing, but
Right.
I was just kind of making a bad joke, if you
Yeah.
will, that, you're mad at them and nothing's wrong with them, but you want to refer them just to be a pain in their side. But absolutely. There might be someone within a church or a synagogue that finds that someone's health is declining. They're not able to go to church like they used to or go to the synagogue like they used to, and you feel like they just need some specialized care or be evaluated. Clergy can refer a patient. So absolutely, anybody can refer a patient for that evaluation. Now they can't be admitted without, a primary care physician or a medical director signing off on that admission, but they can be evaluated. After the patient's death, hospice care ends. We don't just call the mortuary and ask them to come and receive the body and, hey, good luck. As I said, 13 months, we do provide bereavement services if a family would like to have that. I encourage it. At that time, everybody might be like, I think I'm okay. Thank you. I don't need those services. Then the holidays roll around and you kind of feel that depression coming in a little bit and not sure how to shake it off and just wish there was maybe somebody to give me a little direction on how to work through these feelings. So again, you can take a little bit, you could take a lot, but bereavement services are available up to 13 months following hospice. Here we are at the last one. Here's a big, big, big misconception. Hospice dopes people up so they become addicted or they just sleep all the time. Well, no, that is not the philosophy of hospice. If someone is in severe pain, yes, we will give them a small amount of morphine to see if that gives them some comfort. If it's still not helping, it might be just a little bit higher dosage next time. And yes, there are some people that, because of the morphine, might sleep a little bit more. But at the end of life, regardless if they are on any medication or not, that's part of the process. They are sleeping. Think about, kind of look at being that the birth process in reverse. Babies sleep a lot. Well, it's hard to understand, but death, you need to sleep a lot too. It is a process. Your body is going through a lot that we can't see externally. And so they need that sleep. They are going to sleep a lot. So it has nothing to do with, yeah, we're doping them up. That's not the philosophy at all. And again, our clinicians, they've got that expertise in medication management. Some people might be in pain and need a little bit of morphine. Well, that morphine might agitate them. Everybody is going to react differently to different medications. So there might be something that's given to kind of calm them down. I don't know what it was. I don't know if it was because my mom was agitated or because it was something she can control. But she had a lamp on a nightstand and she kept flipping the light on and off. And I kept hearing something when I was out in the living room and I was like, what in the world is she doing in there? And I would go in there and I was like, she's signaling ET or something. I don't know what she's doing. So we talked to the case manager the next visit. And it's like, she keeps flipping the light on and off. And they said, she's a little bit agitated. And so they found a low dose of something. I don't know what it was but it calmed her down and she was a whole new person. We could have conversations with her. She wasn't agitated anymore. She wasn't flipping the switch on and off on her light. So again, hospice is not all about the medications. So again, I'm hoping as we talk to people in the community, there's this whole new perception. Like hospice is not doom and gloom. It's not a negative thing. Although cure is no longer the goal, research shows, we talked about this, receiving comfort care, patients live longer than those who don't. You get that whole spiritual, emotional, physical, it's that holistic approach to end of life. And then one of the coolest things that I can think of, and this is from a personal perspective, when my mom was on hospice, she got to tell us what she wanted the end of her life to look at. She wanted the family to be there. There's a song from church called Something Beautiful that she wanted us to sing, even with my bad singing voice. She told us what she wanted end of life to look like. And if you're in crisis mode, a lot of times people can't tell you what they want end of life to look like, excuse me. So I think it's really, really cool because patients can have a voice. This is what the end of life can look like. But if you wait again to those hours before, at that point, unfortunately, it's a little too late.
Right.
So
Plus,
again, just trying to
you're
educate the
not going to have any
community.
comfort in that person that's working with you because you don't know them; they're a stranger. So if you have some time to build up a relationship, then the family and the individuals all basically get to know each other.
Absolutely. Absolutely. And, sometimes
And
there
then it
is
is an
that,
intimate time.
pardon?
It's an intimate time.
Oh, absolutely. Absolutely. And there are some hospice companies that are like, we will be right by your side while they're transitioning. And we just wanted the family there. We knew mom was comfortable and peaceful. We don't want this stranger, sitting amongst our family circle and that kind of thing. So we were able, again, she wasn't in a hospital environment. So there wasn't tubes and bells and whistles and all the things involved. And, it was a very, as you said, it was an intimate time. It was a peaceful time. And it was a comforting time for my family. So yeah,
What would you look for when you've had obviously within just with your mom's care two different experiences?
yes.
And what would you suggest people to look for? What kind of questions would you recommend people ask as they're trying to decide who to go with?
So if you go to, and I pretty much will guarantee half of the hospice websites out there would have kind of like a checklist questions to ask. But keep in mind that CMS requires all of us to provide the same service. We all have to have a medical director. We all have to have nurses. We all have to, so we all have the same services. So you're going to look for those little things that kind of stand out. And the thing that with the first company that we used is we did not have confidence in our case manager, our RN case manager, making healthcare decisions for our mother or my dad's situation, his wife. For example, we would ask questions and she would kind of fumble around and, I don't know, what do you want to do? Well, we just asked you because we're looking at you as the professional on what we as a family should do. Um, it was simple as she was digging through her bag looking for a stethoscope and it's like, oh, must have left it in my car. Just there wasn't that competency level that we had comfort in. She was 2 hours late. And when you have someone who's on hospice care, my dad had nothing to think about other than his wife at that time being on hospice care. We were brand new to this. And when somebody says we're going to be there at 5:30 and they don't show up until 7:30 and there's no phone call, it's it's a little unsettling. So communication is another thing. So if someone tells me that they're going to call or be there at a certain time, totally understand if you had to be with another patient or had a family situation come up. Just as simple as a phone call or a text. Communication is key. You also want to make sure that there's similar philosophies. Like we have had families like, you know what? We don't want mom on morphine. And so we're going to have that conversation. Okay, we're not going to use morphine. However, if we find that your mother is in such intense pain, let's talk now. How do you want us to address that? So make sure that there is some comfort in philosophies, management, medication management, etc., and that you are comfortable with your team. Um, that is, one of the big things is people are coming into your home, people are coming into your loved one's home, and you may or may not be there. Make sure you have that comfort level. There's things on the background like, are they accredited? How long have they been in business? Do they have their licensure? All of that stuff. If they are out there soliciting, and that's a horrible word, but their services, educating about their services, they darn well better have their licensure and be approved and all of those different things. But there is like a little checklist, but you're going to try to find those things that stand out. Now, here's that one thing that I want to point out. There are some catchy phrases that some hospice companies will use. There are programs that they might create. But you know what? All of the hospice companies are going to do that. They just may not put a fancy label on it or a fancy title. So don't let them say, well, we have this bedside vigil A, B, C, D, E, when you know what? We will provide that as if that's what you're requesting. We just don't have a fancy name for the program. So be careful that, you don't get caught up in that, especially if it's a service that you're really not going to need. Um, so it's just finding, and here's one thing that I recommend, and they didn't recommend to my dad. Don't talk to just one company. Talk to a few. If you have friends or other family members that have been through the hospice experience, who do they use? What do they like? What do they not like? But my dad was literally given a list, shoved at him, said, pick one of these and we'll call them and we'll get them out. And my dad literally said, how do I know which one to pick? And whoever was doing the discharge for my mom at that time said, oh, I don't know. Look at the ratings. So my dad's like, okay, just like I'm picking out a TV, I guess I'll pick out hospice. I'm going to look at the ratings. Well, whoever gave them the ratings must have been friends and family because they were the top rated company, the first company we went with for my mother. It was a horrible experience. So yeah, recommend you talk to more than one company.
Well, that. I mean, that's perfect as far as just getting people out there to understand the fact that they can do that. That there are things to do. It could just be a gut feel too when you're meeting people. If it's just somebody you feel like you
Yeah,
connect with or not, So but
absolutely. And that's one of the things is that we always say, you know what? Families have choices. We respect that. And even if you don't choose our company, choose someone just so you have that specialized care. Um, don't be bullied. There's a lot of places who say, "Oh, we only allow ABC in our facility." Well, you know what? Families have choices. They can't pigeonhole you into a specific. No, they can have preferred providers. And I would ask them, well, why are they a preferred provider? Oh my goodness, they provide excellent care. Their hospice aide comes in and just provides the best care. The communication's great, da da da. So just kind of advocate for your loved one and ask questions.
yeah, that's a big. That basically cuts across all the medical stuff through the entire process is the advocation of what's going on and make
Oh
sure
yeah.
you're listening and paying attention and stepping up when they're getting bullied so
Oh yeah.
by
Well, you've been an advocate for, gosh, since I've known you, I
yeah,
believe, for um not only a parent, but I believe an aunt or uncle or something as
and
well.
uncle as
So
well, yeah. So yeah, and it is one of those things that you need to be there to to deal with stuff. So
absolutely.
Well, thank you so much. I think this was great. I think it really got some information out there. I will have this on Life's Copilot's. What's basically happened, my website, the Life's Copilot website is so cheap that I think that what's happening when I put it on the website, it won't load anymore on the a lot of times when you're doing it by your phone. So I have also Life's Copilot YouTube page, which has all of these, the entire inventory on there. There's a link to it on Life's Copilot as well. You can go to that YouTube page, but that gives you access to this. This will be there. It additionally will go out on our newsletter, which comes out once a month. And then I'll send you a copy to do with as you please. It's on Facebook Live right now, so that's available. And of course, the YouTube will be on there later on as well. So get the word. We'll get the word out to as many people as we can. So,
Absolutely. Well, thank you for the opportunity.
well, thank you. Well, happy Thanksgiving too.
Yes, absolutely. Happy Thanksgiving.
All right, talk to you guys later. Bye bye.
Bye bye.